short, a lively panel session to keep our energy levels up and keep us awake. So what's going to happen in this session is we've got the members of the PCN plus the conference faculty here to answer questions. We've developed some questions ourselves, and we're hoping there'll be lots of questions from the floor as well, and online, which I'll be monitoring and kind of bringing in as per the other sessions. The topic is life beyond primary care networks. So I think we weren't quite sure what was going to happen with the contracts. So we do have a little bit more life in primary care networks, at least for another year. But at some stage, I guess we're anticipating that they evolve further, develop, or become something else in the future. So I spent a bit of time with Gandhi coming up with the initial questions for this. And we had a little trip down memory lane, sort of looking at what's happened over the past 5 years of primary care networks, and then just looking forward to the future to try and frame some questions. And it was interesting because there's a lot happened in the last 5 years. So we've had 5 years of the initial PCN DES contract since 2019. There are about 1,200 primary care networks across the country, which I think is a big achievement. There's been £1.4 billion of additional funding annually going into primary care networks. So it's been actually a large amount of additional money for primary care, not necessarily into the core contractor course, but for primary care and general practice. There's been, throughout our work, we've all had contact with quite a number of primary care networks locally and nationally, and I'm sure you all have as well. And there's been a really varied ecosystem of primary care networks. We've seen some of those examples today, from fully integrated primary care networks with NHS trusts, with their community providers, with their practices like Wolverhampton, who are at the back there and speaking later, to more traditional primary care networks with, say a lead practice employment model and, a number of practices. So lots and lots of variety. We've seen the scope of what primary care networks have been asked to do and who they can employ and what they're able to do evolve a lot over the last few years. Lots of new roles, lots of new functions like extended access, for example, and new functions in terms of implementing integrated neighbourhood teams and modern general practice. As we were saying, we thought there might be an exciting new contract, but it's a little bit more of the same this time, isn't it? With a small increase in the funding, so almost a holding contract for the next year, but we can still look forwards. It's the first time there's been no sort of big increase in funding for primary care networks, which I think is important to recognise. The R's funding has been going up year on year, which has enabled new staff to be brought in. But actually, now that the funding is static, we know some primary care networks who are now over budget, not quite sure what to do about that. That rising tide of funding sort of almost, raises all ships, and forgives, some problems in planning. So that's a first for this year. There's a tighter definition of what primary care networks are for and should do. There are some tighter definitions around what primary care network clinical directors should be doing in terms of shepherding in integrated neighbourhood teams and taking a role in making sure that modern general practice is happening on their patch. Gosh, so much more has been going on. I could carry on forever. The new contract is being imposed, 2% uplift. That's led to talks of potential industrial action, if not all-out strikes in general practice. And, that's the environment in which we're now having to go and have conversations about additional work and integrated neighbourhood teams. So that's difficult. The landscape is looking quite difficult, isn't it? And I think for the first time, we've seen some, maybe not for the first time, but there are certainly examples of and evidence of tension between traditional general practice and primary care networks. So if you look at the employment situation amongst locums and the response to that, the accusations that their jobs, are being taken, they might say, by our staff who have been brought in to potentially do some of the work that they would have felt they could have done before. So we're seeing some tension perhaps between traditional general practice and primary care networks. There's the background of a very poor economic situation in public funding in the country. PCNs and general practice are almost squeezed in the middle, with our patients experiencing cost of living crisis. And then there's a squeeze on government funding, isn't there? And a lot of ICBs are in financial recovery mode with less support available and less funding for innovation, things like integrated neighbourhood teams. So it's really, really difficult. I was going to go on and talk about the 6 health secretaries that we've had in the past 5 years, and there's an election coming up, so there's that political instability that might, that will influence the future direction of policy. And then we'd got to the end without even mentioning, there was a global pandemic, wasn't there, somewhere in the middle, which we've almost forgotten about, thinking about the current challenges. So hopefully we've sort of set the scene and given people some food for thought in terms of potential questions about things that might influence the future. So we will start. So start thinking about your own questions, because we will take a lot of questions from the floor and online. I'm going to start with the first question, which will go to Gandhi first, and then we'll move through the panel. So just, I guess, looking back, what have been the main impacts of primary care networks, positive and or negative, potentially?
So I'm going to try and be brief, because I know me and Andy said we had to be brief. I think there's been lots of positivity when it comes to PCNs. I think it has provided collaborative care across the country. Now, absolutely agree, in some places that's been more positive than others. Not going to disagree with that. But it has been an opportunity for primary care and our patients to experience a different type of healthcare. Now, whether you agree that's a positive or a negative, again, different places do different things. I think there have been some negatives in the sense it's taken away from the core GP contract, and I think many people feel that's why we're in the situation we're in now. Could that be readdressed? We will have to wait and see. Many of us thought that might happen this year. It didn't. It's probably going to happen next year if it does, pending, as Andy mentioned, an election. But I think there are various ways that the roles in particular, which have been the driving force for the PCNs, have benefited patient care and the quality of patient care that people have received. And let's not forget, if PCNs hadn't been set up, our response to the pandemic would have been completely different. Now, even I don't have a time machine, although I sometimes say I do. But let's be honest, we did a pretty amazing job of getting the public through the pandemic itself. We vaccinated thousands, hundreds of thousands, millions of people. And part of that was the mechanism and the collaboration, I feel, that primary care networks enabled us to have. Happy to pass over.
So next, we did have Ben next. And you can come back on some points that
I think it's interesting. So back in 2015, for those of you with longer memories, so before the GP4 review, when general practice was struggling, probably not quite as much as it is now, but it was in a difficult place. And so we had a look at, well, what are the things that general practice could do to be more sustainable? And the things that came out were introduce new roles, because there weren't enough GPs, and that hasn't changed. Operate at scale and generate potential economies of scale, and develop productive system relationships. So the interesting thing about PCNs is what they did was both provide funding for those things to happen and formalize a way of that happening. So they provided a platform, an opportunity for general practice to do the things that it would need to do to become more sustainable. Now, in terms of the negative side, the challenge is that practices are independent contractors and historically very independent. And so that kind of line that exists around the practice is very fixed. And so it's been very difficult in lots of areas for that line to sort of become more of a semi-permeable membrane, so that the benefits that are potentially available through primary networks can be realized at a practice level. So I think the opportunity of primary care networks remains high. I think the ability of practice to be able to realize those benefits has been limited so far, and it's happened much more in some places than in other places. So I think there's still a way to go.
Thanks, Ben. And Tara?
I think from a patient's perspective, I think it has been positive. A patient can use eConsult or an online triage. They can get an appointment or they can get a response from a wide variety of the team. And from a patient's perspective, I'm a mum, I've got 3 children. To be able to just go online, fill it in, get the phone call, get the appointment is amazing. So I think that is really, really good. I think one of the main impacts, and I don't know those at NHS England will understand or appreciate, but I think we've all learnt and appreciated how much time and investment is required to get organisations to work together. And I think people have not, they've unappreciated that. They think you've got some money, you roughly are in the same border, you can work together. And I think they've really underestimated that. And I say like lots of networks are going through divorces, like some relationships are deeply, deeply, deeply fractured and will never, will never go back. So I think one of the main impacts has been, I know we need to think about the patients, but people's working relationships, people's working lives have really, really changed. And I think, there's been a lot of casualties in trying to create this transformation.
Thanks, Tara. I want to move on to the next question. Our first questions we're really continuing to set the scene, I think. We've got some juicier questions later on. But what do you think are the main challenges over the next year? So we're getting quite practical with this question. We know what the contract is for the next year at least. We know that there's some uncertainty after that, so there might be an element of preparing for what comes next as well. But what do you think are the main challenges, and what should PCNs be focusing on when they're rolling their hands up, getting back to work tomorrow to be focusing on for the next year? We've got Tara as the first person to answer this question.
This is a whole question, and there's a million answers to this. But to summarise, I think I've put managing the money. How do primary care networks and when I say primary care networks, I also mean practices. How do we create a model of working that, dare I say, is profitable, like it's worth it for practices to engage? So how do we manage the money? How do we create a model of working that incorporates, how do we trust each other? How do we share data that we've not done before? All of the stuff that is at ground zero, it's still the same challenges today. And I've put down, like, how do we create a model of working which is profitable, is good for patients, is good for the practice, and also fulfills the national strategic objective? And that's the challenge. What do we do with the limited time, money, energy, will that we've got? And I think on a really practical basis, if people ask those questions, you need to bring your networks together and say, this is what we have got, this is what we know. There are lots of unknowns, but what do we do with what we know? And it's like, if you haven't done it now, it's like, just address the elephants in the room. Stop skirting around the issue, because it will just go, like it's Groundhog Day, isn't it? You just go round and round and round and round in circles. So I think the biggest challenges are addressing the elephants in the room and what can we do with what we've got, but we cannot ignore the money. And I think for those of us that are not kind of born and bred in general practice, we need to understand the business of general practice, because otherwise we speaking a different language, won't get it. And if your general practice is not financially sustainable, do not be surprised if they do not rock up to the PCN meeting. It's not their priority. So I think that those are some of the challenges.
Thanks, Tara. I'm going to go to Gandhi next. So what are the challenges, and what should primary care networks be focusing on?
Tara summarised a lot of it. I'm going to try and condense that even shorter, if that's all right. So I think the two main challenges are stability and unity. So we know the finances are awful this year for general practice. A 2% uplift across the board, 2% uplift for the Rs roles in particular. And remember that year on year, we've had significant increases for the budgets for Rs. This is the first year there's not going to be an increase. In fact, the uplift won't even cover inflation, which was just announced at 3.2% today, which is the lowest it's ever been for 2.5 years. That's going to be difficult, isn't it? But increasingly, what we're going to see, I think, for practices as well as the financial impacts of the past few years really bite down on practices, national living wage going up, the fact that there isn't a significant uplift, the fact that everything is increasing in costs. And in particular, let's be honest, people want more money as well. Our staffing is going to be really challenging. And therefore, as a result of that, practices, networks are going to start looking at, where do I get the funding from? There is funding for PCNs. And actually, the ICBs are going to do exactly the same thing. We know that they've got 30% cuts they need to manage. They're going to look at, where can I get more resource from? Everyone's going to look at what everybody else has. And I think the problem with that's going to cause, it's going to fracture that stability where people are stable or have been stable. It's going to cause more discourse. And as a result of that, we will see issues not only with stability, but that unity in places where they thought they were okay, they're going to be in trouble. Places where they have been in trouble, they're really going to tailspin. So Tara mentioned divorces. Let's be honest, we're going to see a lot of divorces happen in primary care in the next year or so, from my perspective. How can we change that? We need to focus on transparency and on unity, because it's not just about the networks, it's not just about the practices, it's about how we keep functioning to make sure we can get through whatever the next year or so is. Does that mean that it's going to be better next year? I think that's the next question, isn't it? But we'll see.
Go on, Ben.
Well, I agree totally. The main challenge is what Tara and Gandhi described. A couple of other things, though, to watch out for. So there's an interesting dynamic change in the PCN-DES where it's up to the PCN-CD to decide if the modern general practice access criteria have been met by their practices. And so that's like the first step towards the PCN managing practices. And so I think it's really important PCNs think about how they're going to manage that whole dynamic and make sure that doesn't become a them and us type thing, because I think that could make some of these things worse. And the other thing I'd watch out for is, so in the planning guidance, it talked about how ICBs have to map the footprint of community teams to the footprint of PCNs. And yet, whenever I speak to anyone, it's about how the ICBs are trying to shift the footprint of PCNs to the footprint of community teams. So there's a bit about how is general practice getting its voice into the system to make sure it is on the front foot in those conversations and not being reacting to what's being put on them by the system. So I think there's some things to watch out for that could come in this year.
Good. Thanks, Ben. So looking forwards a little bit further than this year and into next year, when there will be another contract, what do you see coming? What are your expectations for the next? So get your crystal balls out, and what do you think will come in the next contract? And then there might be an opportunity to say what you hope will come, or what you think NHS England should need to hear in terms of when they're formulating the next contract. And the first person was Gandhi.
It's like, do not.
So what we've got to see coming, well, the big thing obviously that's going to happen this year that's going to change everything is the election. And that makes it really hard to plan, because let's be honest, the government have gone into this state of, well, we're not going to do anything, or we're not going to move forward until this has happened. So a lot of this will probably be decided about 6 months or so after the elections actually happened, which unfortunately is going to be the date of the new contract change if you follow timelines. Does that make it difficult? Yes. Does that mean that we can't predict some things might happen? No. So Andy said to get our crystal balls out. I think we will probably see a mind shift in the way that things like QOF and IIF work. There is a consultation, I think it's just finished, in terms of how, I've forgotten the term, but effectively how they itemize the way that we do work and stuff. And I think, there is an absolute recognition that QOF is not working the way it should do, or people would like it to. So I think we are going to see, a shift in the way that that functions. And that will change primary care across the board, because actually that's how we've been working for the past nearly 20 years or so. I think the contract itself needs adjustment. No one will deny the fact that general practice needs investment, and that actually if you invest funds in general practice, the return on investment, I think in some studies is somewhere anywhere between 4 to 14-fold, depending on which metric you use. But either way, it improves care for patients, it improves the health of our population, it gets people back to work when it can do things properly. Those are things that impact growth, those are things that impact other areas of our system. So actually, if we can see that level of investment, and it's not as much as people think. The problem is everyone assumes it all goes into GP partners' pockets when this happens, and that's not the reality. The reality is that we improve the public healthcare when it can work. I think the big challenge of that is still always going to be the backlog that continues to be an issue. And let's not forget the fact that throughout the year, we are going to see other things happen. In particular, I think we might actually see the first ever GP strike happen. Now, it's not going to be the same thing as the junior doctor strike, but we are going to see changes that impact the way that things work. So what does that mean that we look forward in the future? I'll be honest, my crystal ball's still a bit cloudy, but I think there are some positive things to stick to. The key thing will come down to what the election gives us.
Go on, Ben.
So in the letter that came out about the contract, they said there was going to be a task force on the future of general practice that would start this month. So there's obviously plans to look at general practice in the context of the NHS and what's going to happen. And the policy environment is around integration. So even if you take the Fuller report, right, the Fuller report isn't, how do you save general practice or recover general practice like it used to be back when we had the GP4 review. It was about how do you integrate general practice. So the question that the system is asking is how do we integrate general practice? So how do we connect general practice better with the rest of the system? So if you then put that in the context of the kind of political statements that we've had about the future of the partnership model, so that's come from both sides of the political divide. That started with Sajid Javid. We had Wes Streeton and Keir Starmer talking about it. They kind of went backwards and forwards on it, but it's kind of up there. What is the future of the partnership model? Kind of on the minds of politicians. Then I think, for people who are thinking, oh, well, this might be the last year of PCNs, PCNs are the system's first building block into how we can enable general practice to partner with the rest of the system. It's much easier to link with a PCN that maps to a community team. We can get services started to be aligned with general practice rather than thinking of 7,000 different practices. I think the thing that we'll start to see more of is there's an impatience that exists nationally and an impatience in kind of redesign and transformation and things happening organically. And so I think we'll see moves towards what I would call structural integration. So, general practice being linked in more formally with existing NHS organisations. I don't think imposed on general practice, but I think being presented as a much more attractive option for practice. We're going to hear from Wolverhampton later about what their experience of that is like in practice. But I think we will start to see those kind of structural solutions presented as more of an option for general practice. And that's what I would expect to see. And it's a good idea, but I think it's what we'll see going forward. And just on that then, things like, Agnes and Mike have been talking about in the presentations today. How do you get general practice working collectively strong in an area so that it has an infrastructure it can use so it doesn't need to integrate with another organisation if it doesn't want to, will become really important a year down the line, 2 years down the line, even if they don't feel super important today.
Thanks, Ben. And Tara, what's coming in your mind in the future and how can we be prepared?
So I'll answer the how should PCNs be preparing for the future or positioning themselves for the future. And I just think that, and this is based on my experience, we've worked with about 150 primary care networks. And I think at the beginning, it was like the primary care network leadership team would kind of try to, not in a bad way, but like tell practices what to do. And this is what we need to do. And this is what the DES says. And I think that moving forwards, if it's like, how can practices utilise the primary care network resources to make their lives better? So rather than the PCN leadership management team kind of trying to rally the troops, it's like, you're the practices, we've got these resources, how can we make your life easier? So I think if it's more closer, and it's really hard because I talk about PCNs and practices, but they are, they are the same, but they're slightly different structures. But I think for the PCNs where it feels like them and us, I would be trying to get as close to practices as possible and saying, what can we do to make your lives easier? How can we utilise these resources?
Thanks, Tara. I've got a follow-up question that relates to some of the comments we've just been having online. And those comments are around primary care network money being relatively new money in the system, and that actually other areas of the system have been progressively defunded over the past 5 years, particularly mentioning local government and ICBs. And I guess a lot of people's experience might be that some of what ARS staff do might look a lot like what people working for the local authority might have done in terms of social prescribing. Can often look like the sort of support people might have got through local government channels in the past. Given that that's the direction things have gone or are going in some places, how can we make sure that primary care network resources are used to support practices? Now, that's a complicated question, but I think it speaks to a tension there between that pull on those fundings, and I think you're saying that actually there's a need to pull harder towards general practice. How do you make that happen or create the environment where that can happen?
I think we have a choice. If you we know our patients, we see them every day. We know kind of like I always call like our natural cousins, like with pharmacy, we know where our patients go and they hang out. And we work collaboratively with them. But I think our general practices, you need to come on the same page and say, these are our priorities. This is what's important. This is how we determine how we want to utilise our resources and where does it make sense to outsource, commission, work collaboratively, and what makes sense for us to do as a unit. And I think it starts with us, and we have to be really tight in how we utilise our resources. And I think general practice, I have a presentation called Herding Targets. If general practices don't want to do something, they make it known. They don't just kind of sit back and go, oh no, you take them. Like, they will rise up and say, look, they will put a hard line in the sand. So I don't think it's as challenging to control our additional role reimbursement scheme. I really don't.
So sort of take back control and be true to what those groups of practices really think that they need to achieve with it. That's sensible. Ben, you want to?
Well, if you think about the last 5 years of PCNs, it's been like really rapid growth, hasn't it? And so, a lot of the PCN resources in the additional roles, and it's been about how do we make sure we spend the money, get the bums on seats, make sure don't lose the money because we want to make sure it's there. And so I think there is an opportunity this year to have like a period of consolidation and go, well, have we got the right roles in, right? Have we got, we know which ones feel like they're adding value and which ones are adding less value. Let's do a plan that says, okay, now we've had this experience. How are we going to reshape? We know the resources aren't going to change, but we can reshape. People can come and go. So how do we do it so that adds the most value? So rather than our emphasis having been for 5 years, just making sure we spend all the money, how do we make sure we're using that money in the best possible way to make the best possible difference for our practices and our population? I think thinking about this year as an opportunity to do that would be a really helpful thing.
Can I just say that I think that's right, but I think many networks are frightened to undo the decisions that they have made, especially if you look at roles and you say, I don't think those roles have, it's not been a great return on investment, or they've not generated the impact. Networks really struggle, don't necessarily have the skills to be able to change their workforce. It's it's people's jobs. It's people's jobs, and I think that you have to think. I have to say the word business. I know networks are not a business, but what does the business need? What does this network need, or what do our practices need? But they are hard decisions to execute. If you go, do you know what? And I'm not picking on any roles, but if you go, do you know what? I do not think our podiatrist team has delivered the impact that we would like to, and we are going to make that role redundant, or we're going to make that service redundant. And and I've been part of so many networks that you know what you need to do, but they will not do it because they are scared about employment tribunals or just scared about being perceived as doing the wrong thing. So I agree, but I agree.
I'm looking forward to that. The first question from podiatrists.
No. I've got. Yeah,
but the experience of additional roles, though, is where it's not working for the practice, it's often not working for the role as well, right? And so you do get a more rapid turnover of roles that aren't really working than the roles that are working. So I think just having the plan, right? Just because the podiatrist is left, maybe we're not going to get another podiatrist. Maybe we're going to get another GP assistant, or a pharmacist. Whatever role we find collectively is the one that's adding the most value. So I think just being ready for that can help.
And that builds trust with your practices. So if the practice says this is not working, and then the PCN leadership and management team execute on that decision, it's like, oh, they do listen to us. Oh, they are trying to support us. Whereas there is this like sunk cost, if we just keep trying, We just keep trying. We'll just keep trying. It will be better. So I agree.
Thanks, guys. Oh, that was a nice bit of to and fro. Gandhi, anything to throw into the mix before we move on?
No, I'm just waiting for your next question, which I think I know what it's going to be. So,
It's integrated neighbourhood teams.
you weren't strong enough.
Oh no, that's a reserved question.
Yeah.
We may or may not ask that one, Gandhi. So we did have a session on integrated neighbourhood teams earlier, but not all the panel members were with us, and I think it's something that we could talk about for a long time. So I think we've got Tara. You're the first one for this question, Tara. What can PCNs be doing now? How should PCNs be preparing to deliver integrated neighbourhood teams?
I think many networks need to take a step back and just focus on how can we collaborate. In our network, some networks are not ready to do you know what I mean, start dating other people when they cannot sort their own
themselves.
manager. It's not a great analogy. So I think it's just about how can we start to better collaborate with our natural partners. And I think there is Lauren did a fantastic session, but what can we look at what patient cohort should we be looking at? There's a balance of data-informed decisions and what we feel and know on the ground from what kind of walks in through the door, how can we use our lived experience? And then just asking the question, what could be even better if? What could one or a couple of small moves could we do to increase collaboration before we go into fully formed integrated neighbourhood teams? But, and there is a big but, there are some networks, because of the history, because of their infrastructure, they are ready to go, we've done collaborating, and actually we've got the data, we've got the workforce, we know what we need, and actually we want a commission service. So it's just about understanding your maturity. But for those that are not there yet, it's who can we just start to collaborate with?
Yeah, I was just going to say a few words about that actually, and some of these points came up earlier in the INT session, but I think there's initial period of exploring integrated neighbourhood work and integrated neighbourhood teams where it's about talking, it's about finding common ground, building relationships between those organisations that are likely to be part of an integrated neighbourhood team. But ultimately, I've been in these meetings and there comes a point where actually we're going to have to actually do something, and this will take clinician or other people's time to actually come and work with patients on a project, and in an environment where everybody is short of money, that's often they're more reluctant to take that step than to send one person to a meeting to talk. So I think you have to start getting smart about how you actually fund those neighbourhood teams or those collaborations. You're going to have to find money from within the primary care network DES. And I don't think it's a given that that's where it should come from, to be honest. In fact, I don't really think it should. There's lots of other things that money can and should be doing. So I think people need to get smart about aligning what their integrated neighbourhood teams should and would be focusing on, and look to the data, look to system priorities, look to national priorities like the core 20+5 and 6 major disease strategies to make sure it's aligned with what the ICB and other people might hold some funding that can be approached to commission a service, as Tara says, because I think you need to be quite smart about making that case. And also, I don't think that this is entirely something that primary care networks need to be delivering on their own anyway. In all of the documents that go out to ICB leaders, they are responsible for making this happen as well. So it is about really collaborating with them because they need to make that happen, and it's not all on primary care networks. So those were just a few of the points I wanted to make, but we'll probably go to who's next on the list. Ben.
I just find the terminology really unhelpful. So I'm not sure I know, right, what an integrated enabled team is. So is anyone else not sure what one is? Right, we're leaders, right, in this space, and yet we don't know what it is. And so when we're trying to talk to our practices and our GPs and our practice staff about integrated, they've got a clue what we're talking about. So I think there is a kind of need to unpick it a bit and say, well, is it how the practices work with the community nursing team, or is it, is it how they work with the local voluntary sector? What is it we mean by it? And then use that language and kind of build it up from there. And I agree with Andy. If you can start with, and we're going to do this thing for this cohort of patients, then it will make it more tangible. I think we're in danger of all trying to do something that we don't really know what it is, that's actually making it more complicated than it needs to be.
And Gandhi, anything to?
I think there's something about being the first in there that can make things a little bit easier. So my network, we've been involved in INT for coming up to about 7-8 months now. And it's been a positive experience. We've had some really good outcomes, I think, from that and relationships being built. We're interesting at that point now where everyone else is now looking at what's next, what comes out of this. And interestingly, everyone seems to expect the PCN to fund it all. So when we turn around to them and said, well, actually, this is a collaboration. This is not us to do for you. This is for us to do together. So if you're not with us on this journey, first of all, what the hell have you been doing for the past 6 months? But secondly, the whole point is this is integration. This is about us working collaboratively together. So actually, it's a joint venture. It's not us. It's not you. It's together. And if you can get that across, then I think there are some benefits to be had, and we've seen some really positive outcomes from that. I think a lot of it's been made harder by some of the natural challenges that have happened, particularly obviously the councils being hit really hard. So you may have heard about Nottingham having to go into administration. That's not been great for us. You know, there are real challenges that come with collaborative working, and that has an impact on what you're doing. But I think there is still ways that you can use that to have better care for patients. It's communicating that back to your home teams, as Ben mentioned, which is part of the challenge. What actually does this mean?
Thanks, Gandhi. And the next question will be the last one from our list, and then we'll take some questions from the room and online. So we hear again and again that primary care networks are about relationships, and that's really, really key and important. And I'm just wondering where the panel see warning lights flashing on certain relationships, or where certain tensions might be either already existing or on the horizon between primary care networks and maybe traditional general practice, maybe ICBs, maybe other organisations, and how they would help resolve those tensions. So I think we're going to Ben first for this one.
Well, I was kind of touched on the obvious one, which is between PCNs and their practices, and that's about the pressure of resources. So we probably don't need to revisit that. I think one of the moves that I would expect to see, based on what's been sort of reading the runes, is that it's likely that more funding for general practice will come locally via ICBs than via the national contract. So if you go back to when the Fuller report was written, the letter came from all the ICB chief execs basically saying we should have more money for general practice to directly commission so we can make services more responsive to our local populations. So I think the importance of general practice being able to influence into the system to a point where it's able to negotiate itself for money effectively is really, really important. And I think whilst it might feel to PCNs at the minute like we don't have time to do that joint stuff, we just need to focus on our practices and the work we're doing there, I think by not doing it, it could be setting yourselves up for trouble down the line if we do see that shift of resource from national to local.
And how would primary care networks set them up to make those negotiations?
Well, I don't think primary care networks can do it individually. So that's about how do you have the relationships with other primary care networks in your place-based area? How are you operating as a collective? How are you creating a single voice into the system? In the ways that we've heard described in some of the sessions earlier this morning, but how are you thinking through how to do that so you are in a position to influence effectively? Because it takes time to do that, because PCNs struggle to get on with each other. So speak to Agnes or to Michael or people from wherever, they'll tell you it's difficult to get to that position. So don't expect just to be able to do it because the money shifted. You need to give yourself a run in to be able to do it effectively.
Thanks, Ben. Gandhi, where are the tensions developing in your mind, and what can we do about that?
So if you spent any time on social media, you know there is definite tensions within the workforce when it comes to PCNs, Rs, practice staff, and the reality is that's there. I do think a lot of it, unfortunately, is misdirected. So there's a huge amount obviously being lambasted towards physicians associates and other similar roles in that sense. let's be clear, this was the government direction. This is what they've asked us to do. It's been done, and it's had an impact, compounded by other things like the cost of living increase and various other factors that have happened. But it has caused tension, and it will continue to cause tension because actually we're in a place where there is just not enough resource to deliver care. And actually the reason why people are now in employment situations is not just because the RS roles are functioning and working within general practice, but it's just the fact there isn't enough resource in the system to do what we used to do, or to even try and do what we're currently doing. So I think that's where a lot of the tensions are coming through. How do we make that better? I'll always go down to it's about transparency. It's about honesty that actually certain cuts do need to be made in general practice, because just like everywhere else, we're being asked to make cuts, whether we like it or not. Absolutely, we would love to have more resource because, again, I go back to my earlier point, better functioning primary care has a return on investment time and time again. We just need that to happen. But when will it happen, etc.? Harder to say. I think those tensions aren't going to go away. I think in how we can improve them is simply get people around the table, explain what the problems are, be transparent. And I think that's one thing that we sometimes find really hard to do, because it actually goes back to the point Tara made earlier. General practice doesn't run like a business. But let's be clear, it is a business. You have to look at it that way, whether you like it or not, whether you agree with it or not. Because if you don't, that's when people are going to go under. And actually, I think that's the thing we're going to start seeing very soon. And let's be honest, we already have.
Yeah, if not already. So thanks for that. I think, so this lady here, if we just run with the mic, if we just wait for the microphone just so people online can hear things.
Thank you. Does the panel think that development of primary care networks, commissioners commissioning at scale, and effectively PCNs becoming stronger, bigger, more mature, does the panel think that that threatens the general practice partnership model?
Good, very clear question. I'm going to go to Ben first.
Yeah, so
Indicate who wants it.
Yeah, it doesn't, but it could do, right? So a lot of it comes down to how PCNs are led, how PCNs are run, and the culture in PCNs, and the extent to which that reflects that of general practice. So historically, there's people in the room who've been running federations for longer than some of us have been around, and the challenge is the at-scale entity supporting practices or in competition with practices? And the mistrust that builds up is practices feel like, well, yeah, PCN, federation, they are doing stuff that we could be doing and taking work away from us. Whereas if the collective work around the members, so the practices, being clear what it is they're trying to achieve collectively, how that then benefits the individual practices, and then having this constant cycle of communication and engagement in that, so it's maintained over time. Because you can have it at the start and it can be gone 6 months later because people just can't seem to hold this as a thing. So it requires really good leadership, and I think that's why we're seeing such variation around PCNs around the country. So some people love their PCN and they don't understand what all the fuss is about with, why do people hate PCN so much? It's working great for us. And others, it's just a bloodbath every meeting where they're fighting for resources because it feels like we're in competition with PCN, competition with other practices, and why can't they just give us the resources ourselves so we can make it happen? So it could go either way, but the opportunity is there for it not to do, and it's about how we make the most of that opportunity and make it work for practices.
Gandhi, you want to come in?
So I'm going to say that, as you're saying, is bigger better. Yeah. So my answer to that is yes and no. What did you expect? Okay. So yes, in the sense that I think bigger can be really powerful. And I think collaborative work, economies of scale can have significant impact. It's something I've bought into myself as well. And I think it can really deliver care. I think the part where it goes no is just simply being bigger. Bigger doesn't mean being better. And the reason for that is, let's look at history. Let's look at the past few months. We've seen Babylon collapse and fold. We've seen Operos collapse and fold. These were some of the biggest practices in the country they couldn't make it work. Why? Because there's actual step changes when you start getting bigger. There's a massive difference being a 2,000 patient practice versus being a 5,000 patient practice versus being 10,000 versus 20,000 versus 100,000. And sometimes those step changes don't scale, and they don't scale very well and quickly in general practice, because actually general practice has a completely different ethos. That's the key part. When it comes to scale, when it comes to size, it's about the ethos that you take it. If you take people with you on that journey, it will work. If you make them part of it, it will work. If you just become bigger for the sake of it, it's not going to work.
Gandhi, some people might say that the difference between the organisations you've described as failing there to some degree and smaller general practice is the partnership model. And actually Operos did not operate with the partnership model. They were an at-scale salaried service. I'm less clear about Babylon's operations. They did a lot of different things. But to what extent do you feel that the partnership model is a positive or negative or supportive factor for general practice?
So I'm going to shock you and say it's both.
I'm not shocked.
But why is it both? Okay, so the partnership model, I'm a massive fan of it. I've been a partner for over 10 years. I buy into it. And, you know, the responsibility I feel of being a partner to deliver care to my patients, to work for my staff is there. And it's always going to be something I'm part of. That's something that requires buy-in. It's something that requires dedication. It's something that actually delivers amazing care. Because, again, I'll go back to it. Why did general practice do so amazingly during COVID and during the vaccination? It's because we wanted to look after our patients, we wanted to look after our staff, we wanted to look after primary care, and we did it. I think the challenge that you see as a result of that in terms of how it then comes out is more complex, because actually we also know that by doing all that stuff, part of what you give is yourself. And unless you're working with people that support you and help you do that, there's a point where it hits burnout. And that's what we're seeing in so much in general practice right now. People are just burning out left, right, and centre. And unfortunately, they're not being supported because everybody, like I said earlier, everybody wants their own little piece. And that's becoming a bigger part of general practice, unfortunately. Where will we end up? Crystal ball, I don't know. I can't give you that answer right now. I think we'll see. But I think the part comes into it is buy-in, it's the ethos, it's the way that you approach it. If you do it right, if you do it collaboratively, it will work.
Okay, let's get some hands up. I think we've got 2 microphones, so we can get the next question queued up as well. So hands up for any questions. While people are loosening their hands, I'll just make a point about scale, actually, because it was one of our questions we prepared. And I think that in some ways, general practice is a lot more like running a hairdresser's shop than it is running a supermarket, for example, because it's quite, at the end of the day, it's people interacting with people, and it's quite a personalised service. And I think there are elements of those sorts of businesses that are actually quite challenging to scale and do big. I think there are parts of what sits behind that interaction that you can scale, you know, that lend themselves to economies of scale, but the actual work at the coal face, at the shop face, is actually very difficult to scale. And I think that's why we see lots of independent hairdressers as well as hairdresser chains, but we don't see quite so many independent grocers shops. So it's just a comparison and observation that I often like to ponder. So I think there is space for partnership model based on that thinking. So hands up, there must be sort of questions, or, you know, if you don't have a question, you can, we've got one here. There we go. It might be that you have a point that might stoke some discussion in the room as well. So it is okay to make shortish points.
Andy, if not, we've got some online questions as
Oh,
well.
we've got online questions. In fact,
Right.
Andy, you do the online questions, I'll do the room. And far away.
Donald Collins. I'm a retired GP, but was around for a long time and set up a GP federation, much like Ben did many years ago. Just a question for the panel. Is anyone thinking about a system integrator? And so system integrator is essentially a policeman in the middle. So general practice does its bit, hospitals do their bit, and if you collaboratively do things together, you make savings. An example is Optomedes in Germany. They make 6% savings cost year on year. And that savings is funding them to continue. So about 5 years ago, they said, tomorrow we stop as our fundings run out, and they then got a 10-year contract.
And what was it then? So what did they do?
Very simple. They just looked at the data, looked at what worked, asked people why they're doing something different over here than over here, talked about it over a beer in a friendly way, and then held people to account. You in the hospital said you were going to do this and you didn't. You out in primary care said you weren't going to do this, you didn't. It was just having conversations and keeping people to their promises. And then they used data to evidence everything.
Good question. I was just going to make an observation that beginning to see where it's done well, place an ICB, sometimes asking those questions and providing the data in the way that you describe. So that's just an observation, really. I'm not sure whether we would call them a system integrator, although that may well be the intention of those organisations. Gandhi, you indicated.
I think we've already had something like that happen in Nottingham. So actually, I think the Centene Corporation did something fairly similar.
The idea was based on that Spanish model.
So based off the Spanish, I've forgotten near Valencia.
I can't remember.
Yes. And they were trying to do that exact process. They were trying to integrate the way that primary care and then CCG, as it was transferring to an ICB, in with various other aspects and saying what they could do. I think the challenge there, and I keep saying this, it's buy-in. It's getting people on board to do it, and also getting them to agree to those contracts that mean that actually if they don't achieve what they're meant to do, then they don't get paid. Because let's be honest, that's where a lot of parts of the system don't like being. They won't sign those contracts because they know there's a distinct chance they might not do what they say they're going to do. Yet general practice seems to do it time and time again.
Yeah, a lot of what was discussed when we were having that work done in Nottingham was the transfer of resources from secondary to primary care to focus on prevention and reduce spends in secondary care. But I think it must have been that they're changing the contracts and getting change within the system around secondary care contracting must have been too challenging, because I haven't seen it happen or emerge to date. Does anyone else on the panel have anything to?
No, when you said that, I just wrote down like ICB question mark. So
that's what I thought as well.
So I've not heard that term. It makes sense. And I think in some areas, the ICB tried to be that convener, that boundary spanning role to say, have you thought about this or this data? But it kind of, there's something that stops it from, like really progressing in some areas, not in all areas, but I think, I don't know if it's time, skill, that stops it from...
The worry, for me, the worry is the system will say, well, we tried that, right? So you've seen in the guidance, right? So secondary care is supposed to have a primary care lead to make sure that all these things that secondary care is supposed to be doing are done. I don't see how having a lead is going to make that happen. And so where do you get to? So the system, because this is just the way the NHS thinks, will go, oh, we just need to merge the organisations because that will get it to happen. And so then you get into that as the answer. And then when we get any better, it's just people will assume that's the answer. And so I think the challenge is really about how do you have the relationships in primary care, because just someone's in an ICB from general practice doesn't mean they can have things happen across 19 practices, and just in the same way in secondary care they can't get their consultants to do things. So that doesn't work. It's about something more. So I think because we're so top down in the NHS, it works against that way of working.
So Gandhi, I think you've been able to keep some of your attention on online.
Yes, so just a comment first of all from Sarah Cole, for the gentleman speaking, isn't that the role of the good ICB? I guess they probably are, if that's what they're doing. But I guess the question we had also from Sarah, so putting it on screen for those that are watching, how can we ensure NHSE recognise and retain the importance of local flexibility within the PCN model/contract? So often they cherry pick what works in one area and try and wholesale roll it out to all, which means we can no longer tailor services to meet our local population's needs. I think just before we answer this, I think one example I'll give of this is the concept of a same-day service, because actually that's what Phil Wallach, who's going to be talking in our next session, is actually talking about, and how that model was possibly tried to be transposed in various other areas. And many of you probably remember the whole Northwest London ICB on mass procure, trying to make that happen in one go. So I think there's an example of that question and how it can work and how it doesn't work in different areas and stuff. But yeah, passing the question over, and I'll stop talking there.
So the question is, often things work in one area and then they're taken to apply to all areas, and often that drives the national policy based on cherry-picked good examples. How can we stop that happening? Or maybe it's a good thing, Ben. What do you think?
So there's a couple of things to say. So one is there's such variation across integrated care systems and how they function in relation to their primary care network. So some are very hands-off and supportive and they want them to do well and want to invest in them, and some are very, directive, and you've got to put all these forms in if you want to get any resources. And there does seem to be a big difference about how that operates in ICBs. So that immediately makes it difficult. The other thing is, it's like the age-old question that the NHS has struggled with for years and years and years about this idea of diffusion of innovation. So if one place does something good, they sit, in Whitehall or Richmond House and go, everyone should just do that and the NHS would be better. I like it's easy. And so the answer of the NHS is to say, right, you all have to do it. But of course, no one gets it. It doesn't work in each area. Every area is different. And so whilst we maintain a top-down model of just telling people this is what they have to do, we're not going to get the answer that working. There has to be trust from local systems and local areas to develop solutions that work for them and recreate solutions in ways that work for their populations in a way that's going to get the results that the first place got. And they will have to do it differently to do that.
Thank you. I'm going to ask, we're nearly out of time actually. I'm going to ask one of our reserve questions because I think it was a challenging question and we'd said we'd ask some challenging questions. It's quite a direct question actually. Should GPs be included in ARRS roles? I'll go to Gandhi first. You might have the most formed opinion. But
So
yes and no. Is that the answer?
I was going to say. So yes, they should be funded by the PCNs to do specific roles. Should the role of a GP itself be funded by ours? Well, no, because ours by definition is an additional role and general practitioners are not an additional role. So I can understand
We've got enhanced additional nurses now.
Well, let's be honest, it's a fudge just to make
Okay.
people happy, in my view. But I think in terms of, GPs doing specific things to provide additional services to their local population, such as safeguarding leads, such as frailty leads, absolutely, that is delivering amazing care to our patients, which allows the mechanism to flow effectively. And let's be honest, it would probably work really well in most places, just like pharmacists works well in most places, just like physios work well in most places, and just like the plethora of other roles do work well in most places. It would have impact, in my view.
Go on.
I think they definitely should be able to be, right? And I don't understand why, in the contract negotiations, NHS England wouldn't allow GPs to be funded by the ARS roles. Because if you are saying that the problem is that the envelope's fixed, that the NHS can't afford any more money, and GPC are saying, well, practices are going under because they're having all these cuts, what they could do is use the money that's already there in additional role reimbursement scheme to enable practices to be sustainable. So it seemed like an obvious thing to allow to happen. See, the idea of additionality only works if money's going up. But if you're in the context of huge cuts because of inflation, so practices are experiencing huge cuts, to then say this pot of money, nearly a fifth of the money coming to general practice is additional, even though about all these cuts, so can't be used to deliver keep the core services running. It makes no sense to me. It's just crazy.
Thanks, Ben. Tara might be about to disagree with you. I'm not sure.
I don't think they should. I don't think there's enough money. I think it would really destabilise the existing. They would do your stock take and go, do you know what? We don't need any of these roles. We want more GPs. So I think that I understand what you're saying, but I think that I personally don't think that GP should be funded by the additional role reimbursement scheme. I think it would undo so much work. And are the GPs even out there? And speaking to that lady's point, I think you would then start to see PCNs be a threat to the partnership model.
But how can we have a situation where we're 6,000 GPs short and we can't even afford to employ all the GPs that we do have? It doesn't make any sense. There's no way all that money could be spent on GPs because those GPs don't exist. But we've still got a situation where there are GPs who aren't being employed because practices can't afford to employ them. It doesn't make any sense.
I'm so glad I asked that question. I won't do a show of hands out there.
Oh, no, let's do a show of hands.
Yes, let's do a show of hands. So So this house believes that GPs should be included in the ARS funding model. So raise hands.
Feel free to join online if you are watching us.
So keep them up. Keep them up. Okay. I'm just wondering how many of those are GPs. Keep them up. If you're not a GP, okay, up again. And if you're not a GP, put your hand down. So you've still got your hand up if you're a GP and you believe they should be included. Okay, so quite a number of people who aren't GPs felt they ought to be included. I mean, for the record.
And then I want to take a picture.
Hands up again.
Hands up who thinks that GP should not be funded by the additional role reimbursement scheme.
Okay.
Thank you.
Okay. I was going to say what I thought really. I don't think I should have a fully formed opinion on it, and I'm not sure I do because I think it is quite nuanced. But part of me thinks actually it can be problematic when you really try and impose a lot of rules on how you use money within something as complicated as the NHS and the jobs market. To kind of try and design that market. I think there are lots of examples of where that creates difficulty. So part of me just is actually there is the demand out there for GP appointments, which is building, and if the service providers feel that's where the demand is and that's where the funding should flow, part of me wants to come down in that direction.
So we've just finished PCN Plus live conference, and as you can see, we're in this lovely room that most of the event came from. I'd love to know what you guys thought of the day. How was it?
Well, I wish more than this number of people had come. Would have been so much better.
Definitely. But thankfully we had another room that was definitely full of people. So if you didn't know, we had over 100 people live and we had over 150 people join us online. Tara, what did you think?
I have finished the day feeling really inspired. I think that with or without primary care networks, there is so much collaboration which is taking place and which will continue to take place. And I think that's really, really inspiring. I think there's so many people, so many examples of what is working well, but people are also really honest. And yeah, it's been a really fun day.
Cool. And I know, Andy, you and I have been running in the background trying to make the tech work. Hopefully it went well for those people joining us online. So what did you think of the day?
Yeah, I mean, I feel exhausted at the moment. for making the tech work and looking after the speakers and the sponsors. I had a really good day, and it's been really nice actually just spending some time at the end of the day speaking to some of the delegates and also the sponsors, and hearing that they feel they had a really good day, that they learned a lot, that they valued that we had lots of different examples of different models and different things that are working, that we encouraged everyone to be honest where things aren't necessarily working as well as they could, and people were taking away lots of ideas, and I'm taking away a lot of ideas myself as well to try and integrate into the system in Nottingham. So I feel it's been a really, really good day. And Gandhi, so how about you? How have you found the day and what's your take home?
Well, as Andy mentioned, absolutely shattered, to be honest, but it's been an amazing day. We've got to meet some really cool people from across the country. Rachel's sessions were amazing, so I had the pleasure of watching both of them. I apologise that you guys can't see the recordings from those, but if you do ever get the opportunity to see Rachel, absolutely take it. And you mentioned honesty. I think, so we had disagreements during our panel in terms of how we perceive what happens with networks and various other aspects. So I think
It's me and Tara, really. I don't know.
Well, it wasn't all rosy, but that's general practice, isn't it? So I think, if you do want to check out the content, absolutely have a look. You can still access the recordings. It's still open and available for you to do that. So it's bit.ly/PCN plus 24L, all in capitals. We'd love you to catch it up and stuff and things. And hopefully we'll catch you here next time.
I'm super excited to be working on the PCN Plus 3 programme with you guys. I think it's going to be even better next year.
So people can check out that as well, can't they, online? And
absolutely, managing the uncertainty of what's coming this year and even more so possibly next year. If you want to find all that out, absolutely. If you want to hear Ben, Tara, Andy and myself, you need to be part of the course, the community,
do it.
and basically the experience. We'll catch you next time.